Hello and
Morning.
welcome. Good morning to another episode of Confronting the Complex with Dr. Jamie Kunkle and Dr. Janell Payne. Today, we're going to talk about a pretty interesting subject. It's sort of a continuation of what we've been doing with our ND series so far, our Naturopathic Doctor series. This one is specifically going to talk about ND bias, so biases around naturopathic medicine. And of course, there are biases all over medicine in general, so it's not just NDs that are subject to bias, and it's not that we as individuals are not subject to giving bias or presenting bias in our own lives. So I'm not here to discuss all those philosophies, but they're very important nonetheless. But where I'd like to really start today is in the early 20th century, 1910. But before we get to what happened in 1910 that is relevant to this conversation, Janelle, you have any thoughts, any introductions? Hello, and how are you doing?
Hello, I'm good. Good. Happy Friday. I'm glad
Yeah,
it's Friday.
I know.
TGIF.
TGI. Yeah, jinx.
Yeah. No, it's interesting. This topic is, I mean, this was your idea this week. And so I have to admit, I kind of warmed up to it. And then I'm like, oh, this is kind of an exciting topic. Now I'm kind of, yeah, I feel a passion in talking about this topic today.
Good. Yeah,
Yeah.
I think
Good pick
yeah,
for the week.
there's some interesting stuff in here that we'll get to, and some of it's a little scary also.
A
I
little
have to
fired
say,
up.
like
Gets me a
a little
little fired up.
fiery. Yeah, it
A little
gets me a little
fiery.
upset. What it comes down to, I'll just dive right into it. That like the
Yeah.
Flexner report was something I learned about in medical school in my first year of school, and I think everybody should have learned about it in their first year of medical school, no matter what
I
medical
mean,
school they went to.
right.
So, the Flexner report was created in 1910 by a group of individuals, but largely this dude named Flexner was the one that was actually uh, placed on this as
Is he
the
a medical student?
major author. Actually, you know what he was? I believe he was a teacher. He did end up going to Johns Hopkins. I believe he didn't come from a very wealthy family, but I believe he was paid for by I believe it was his brother who was a pharmacist or something like that. So he was a teacher, I believe, prior to that, and so he was a lot of the money that came into doing this report was funded by philanthropy at the time. So the Carnegie family and the Rockefeller foundations. So Abraham Flexner is his actual name here, and there was a group uh, at the time that was kind of going to go around, and they were sort of, once again, paid for by these philanthropists to go around to all the different medical schools in the country and in the surrounding areas and present a report on, what's being taught, who's teaching, uh, what are their proverbial standards? Unfortunately, there was bias in this to begin with because there was a little bit of an agenda here in terms of what they specifically were looking for in
Was
a
the
medical school.
agenda in place by Flexner or was the agenda by Carnegie and Rockefeller?
Huh. Well, it's a good question. I mean, I think it was more this circle of people, William Welch, um, this Abraham Flexner guy, what they called, let me see here. I think it's called I got to get back up to my top part of this discussion here. They had something called the Hopkins Circle. So I believe this started, with people in Johns Hopkins, with
In their
Flexner being
medical school?
one of those people.
Yeah.
Yeah. Yeah, within their system. And so the Hopkins Circle was a project that was meant to once again review these different medical schools and medical education at large. And so they created sort of a group that was, committee kind of thing, I guess, that was sort of charged to research this. So they had
And the goal
Abraham.
was, sorry, was the
Yeah,
goal to standardize everything? What was
The goal was to figure out what an appropriate standard was going to be in medicine going forward, because there were just so many different ways that people were practicing out there. There were reforms that needed to happen. There were a lot of for-profit systems that were out there, and people were coming out with really questionable education. It's important to understand that there were not a lot of good quote unquote doctors out there, and there was a lot of the proverbial snake oil salesmen or whatever. I mean,
that?
there were real stories about people taking advantage of people at that time, and coming out and doing more harm than good in communities. So there was really a need for reform at the time. It's just that the people who were charged to make the reform were coming in with their own set of biases and their own set of ideas of what the best thing was going to be. And they largely based it off of the German biomedical model that started several even centuries earlier. Just the what we think of today as the scientific model or the scientific paradigm. It has to do with you know rigorous scientific studies and evidence-based medical practice, sort of getting rid of a lot of traditional things, but really only keeping the things that were largely proven by a standardized scientific method. So that, yeah, as you can imagine, it sounds kind of okay on the surface that like we need more science in medicine and we need to not harm people.
Right,
That makes a lot of sense, but it's just who decides then who the authority is on what is good science and what is not good science.
right.
And then, who is allowed to learn this knowledge. Because ended up happening, unfortunately, and I'll get to this, is when they were going around to the medical schools, they were not very favorable toward natural medicine, homeopathy, and sort of other traditional medical systems, as I mentioned. But what they also weren't very favorable toward was women and folks that were not, essentially Caucasian. So they also shut down several, uh, black schools of medicine as well. And they sort of just said that women are supposed to basically maybe stay in obstetrics or, childbirth and delivery and stuff like that. So they also kind of turned the idea of who a good doctor was into one that follows a rigorous scientific system of thought and, is scrutinized on whatever that scientific standard may be. They're a male, they're white, and they're usually wealthy because, a lot of these schools still incidentally stayed for profit and weren't always easy to get into uh, within these systems. And so it's still sort of like, shifted how what was considered a good doctor and what was considered good medicine. And incidentally, it did embrace a lot of pharmaceutical drugs and what we think of is modern day allopathic medicine. And so,
Yeah.
of course, we as naturopathic doctors did suffer with this. But the other thing that it did that I think was really harmful, and we'll talk about more of this as we go, one of the harmful things that it did was it emphasized the importance of research and science over bedside manner, like in terms of the relationship with the individual and individualized medicine and everything. And so it used to be that these centers were created for health and wellness and, mental health support and different things like this. And a lot really went into that. And instead, it kind of came down to, is this medicine good for people by our rigorous scientific standards? And then, you know, you treat the disease, not the person. So we're
Right.
going to say this medicine is good for this pathology and this disease, not so much what is good for the individual. So in contrast, naturopathic doctors at the time had really been one of the systems, and there were others too, that had really emphasized the importance of individual medical practice and care. And we're relying a lot of times on traditional therapeutics, and we're not necessarily as quick to embrace modern pharmacology practices and chemical drugs and stuff like that. So it was kind of a way in which to kind of cut off the competition a little bit too, because like I said, there were a lot of for-profit systems, and you can kind of speculate as to why,
Right.
maybe some of these philanthropic organizations like Carnegie and Rockefeller were even funding it to begin with. Of course, they did have connections with these individuals within this circle. Uh,
And if you look at it today, not a lot has changed today. If you look at the
no,
funding of these schools, the funding of ND schools is primarily through tuition dollars of students, right?
right.
Which is a
Hmm.
problem. We, you
Yeah,
know, we all acknowledge that there's a problem with that, right? Cost of
precisely.
education, all that, and that's a whole nother topic. But if you look at the funding of these medical schools, still the allopathic medical schools, you'll see a lot of pharma money, you know?
Yeah. I mean, and that's really the problem with this whole thing is that after that report in 1910, it set it set things on a course that we essentially are still dealing with today. Like a lot of the systemic
100
changes that
years later,
happened 100 years over 100 years
100
later,
years later,
115 years
shocking.
later, we are still operating under that system. And we've made some changes, and I mean certainly this paper that I was citing here while I was reading and probably looking down a few minutes ago, it was a PubMed published paper on the Flexner report that was made by an author in 2011. And if anybody wants to know, that author is from
I was just gonna ask.
Yale Biomedicine, and it's Thomas Duffy. Thomas P. Duffy was the author of this, and he had sort of called at the end for the need to create a new Flexner report, and the importance of uh, innovation and change, I think, in terms of our perspective on what is good medicine and what we need to focus on, and the balance between personalized care and scientific models in terms of, you have to balance those two to provide the most effective and humanistic care, to be
Yeah,
the best human to other people. So,
yeah,
um, so anyway, that's kind of where it started, and unfortunately, it did lead to a lot of other really terrible things, which I won't get into too much. But for example, the Tuskegee experiments, people hear that thrown around a lot, but that was a study where they had essentially allowed multiple men, African American men, mind you, to be infected with syphilis, and they deprived them of treatments, even up to the point in 1972 when it was exposed and they stopped the experiments. And by that time, several of the people had died, and then they had transmitted to other people, and then even their children
their
had had
wives,
it, and
wives,
yeah, and their
children.
wives and the children and everything. And
And
it was
how
just
long had
crazy.
penicillin been out by then?
Well, since 1947, so it had been out
Right.
for almost 30 years
Very,
by the time the
very
experiment was
treatable.
done, and they could have actually just treated people. So that's where that dehumanizing sort of comes in with a lot of this thought, is that for the greater good of science, not necessarily the person, we are going to study things. But I mean, that's just crazy to think, because that was like the stuff that the Nazis were doing, right? So
Right.
like we were doing that
Horrific.
here in in our in our homes. And I'm not trying to say, I said that a lot of what the Flexner report was based off of was German biomedicine, but that doesn't necessarily mean that that was part of German biomedicine. I mean, the not it just so happens that Nazi Germany happened in Germany, but that same line of thought was happening in a lot of places in the world, that we need to research, we need to learn and understand, and for the greater good of science, we are going to do that against our own humanity or against compassionate care or anything like that.
Right.
And another,
Sacrificing people. That's
exactly.
horrific.
Yeah. And one more example, which is interesting because I worked in a microbiology lab in my undergrad, and we used something called HeLa cells, HeLa. And so these cells came from, once again, an African American lady named Henrietta Lacks, and they collected these cells on a biopsy for a cervical cancer, and they ended up learning that these cells were immortal, meaning they never died. So they took these cells in 1951 from this lady. She ended up dying from her cervical cancer, and then they used those immortalized cells even up till today for research, and it was a fairly robust industry to create these and they sell them, and they were
What
still
kind of
doing well.
research do they do with these HeLa cells?
Well, I mean, they're just a human cell line, so they're a stable human cell line to some degree. Though they are cancer cells, they don't really change very much over time. So they kind of have a little bit more of a little less variables, I guess, when you're studying them because they're just sort of, human cells. You have to take into account that they do act different in some ways,
Right.
as in they never die, like they just keep replicating infinitum. Uh, but that they are a human cell line, so they're not, a rabbit or a dog or whatever else. So they're often just used for like, well, in our case, we were using them for, I think, cell trafficking research and different things. So you could see sort of how things go in and out of the cell with them or how normal cellular function or whatever. There's a lot of different uses of them. That's probably, just one of many. So, but yeah, because human cells and samples do cost a lot and kind of, like I said, have kind of a shelf life sometimes, so you can't necessarily get like always good fresh live human cells, but HeLas are cheaper, easier, simpler. So yeah, and that family never really got. I mean, I don't know to this day if they ever did get compensated. They might have. It came up again, like 10 years ago or so, as to like, but the family didn't even know that her cells were being used for this purpose. So once again, for the greater good of science,
For the
for
great
the
good.
for the greater good of the university and for the greater good of the medical industry, once again, human basic, basic human compassion and uh, care was sort of thrown to the wayside. So anyway,
It's interesting that the for the greater good is coming up quite a bit, right? That's a common theme
yeah,
amongst all this is it's for the greater good, but that loses that personal approach.
it really
Like,
does.
and I know you've emphasized that, but I'm just affirming that, you know.
Yeah, I agree. And it's important to say again, really, because so that brings us to sort of where we are now, because that report and what happened since that report is still a big part of the system and the institution of conventional allopathic medicine. And
Right.
so it's easy to then imagine why,
Wait, but not
what,
these experiments and such.
no,
That's
no, no,
that's
no,
not what
just
you
the,
mean. Okay. I
no, no,
just
I
want to
meant the,
clarify that
yeah,
because
of course,
that could be easily misconstrued.
no,
I
totally,
get
no.
yes.
I meant just the Flexner report in general, in terms of the scientific thought and what is considered good medicine and not good medicine, sort of how systems are operating in terms of patient care and what's considered important in patient
Yeah.
care, even all the way down to what we've discussed before about like how long do you spend with a patient and what types of things are there to support everyday patient care within a clinic structure, within a hospital structure, and everything else. Uh, all of it is still being influenced and affected by this standard model. And once again, that model benefited certain people in the society. First of all, white males, it
Right.
did. Which, second of all, uh, medical institutions and businesses in that regard. So medical institutions being like hospital systems and various things like that, and then the pharmaceutical industry, so the ones making the pharmaceutical drugs and everything. So those institutions, those systems became very, very powerful and very, very big, and it made sense that, as the wisdom goes, if you're benefiting from the system that's established, you're not going to really fight to change that system unless
Right.
it's like you're doing it out of the goodness of your heart, maybe.
And
Uh,
once again, we see the pendulum just swing too far, right? There could have
yeah,
been a little bit more moderation at that time, instead of cutting out the osteopaths and naturopaths and, you know,
yeah,
and they didn't. It wasn't moderated. It was like they kind of got cut off, essentially cut off at the bottom.
totally. Yeah, and I mean it's funny because in the case of osteopaths, they ultimately were sort of allowed a seat at the table, and but in order to have a seat at the table, they had to embrace this
That,
model
yes.
of practice and treatment.
And that
And so
didn't
I don't
happen
want to
until like
say
the
they,
70s,
you're right,
right?
exactly.
The
Yeah,
70s, right. So
yeah,
allopaths were out, and now DOs and MDs are virtually a synonymous degree.
right. Yeah, there's
Wouldn't you
not
agree with it?
much of a difference now,
Right.
really. So, and
I'm
so
sorry for the DOs out there. They're probably thinking there is a difference. There might be a little bit of tribalism woven
there
in
are
there
individual
where,
differences for sure.
Yes.
In other
Yes. So I don't
words,
want to be a generalist.
no, I don't either. I'm not trying to, bag on the profession or to say that they sold out or anything. But I'll
Absolutely.
just say the opportunities that they have are the same. They can
Yes.
go and get residencies. They can go and learn surgery. They can,
They can be
get
board certified.
they're licensed in every state. They can be boarded, all these things, and so they have all of the potential rights and privileges of allopathic medicine.
Yes.
So that's really my qualifier when I say they're not much different. Not so much that the individual isn't different, because I mean every individual is different in
Right.
medicine, but
Right.
certainly I know a lot of good osteopaths, so like I'm not, it's that classic story. It's like
Right.
I'm not biased against osteopaths. I know a lot of osteopaths. It's-
I mean, patients still ask me, well, but they're a DO. Do you think that that's, and like, uh, yeah, I think that
Not a
they're
guarantee. It depends on what system they're operating in, actually,
right.
more than anything. If you're gonna judge them, if
No,
you're gonna
but I
judge
mean,
them,
in a case to not judge them, right? Like,
yeah,
of course they're equitable. Like I feel like we all have a seat at the table, and
right.
yeah. Anyway,
Yeah,
I,
no, totally. And I
they're
wasn't
well
even
trained.
meaning to judge. It's just more like, yeah, if they say, okay, so the letters after that person's name, that means they're probably going to be a little bit more, holistic or have a little bit more bedside manner. Yeah,
Yeah,
maybe.
but
It's
not
possible, but
necessarily.
you can't. But it's bias any way you look at it. It's like you're either having a bias then against the MDs and saying the DOs are better, or in my case, I have a bias against the system. So my bias is against the system in which they operate, because generally speaking, that system encourages more of the Flexner way of operating and a little bit less of, as I said, the way in which we operate as NDs,
Yes.
which,
But can I share how frustrating it is that that's a system that we strive to be a part of? We have a beef
yes,
with the system, but at the same time, that's the only way that, like, we are trying to join them, right? If you can't beat them,
right,
join them type of thing.
right,
And mainly for economic success. I mean, we're graduating with massive student loan debt. Uh, Student loans greater than some MD/DO schools, right? And we're coming out with higher debt to income ratios, yet our opportunity is dramatically smaller, right?
right.
We don't have pay parity. Like we could go on and on, right? With the
Yeah. And so the system, unfortunately, and this isn't conspiracy or anything, but the system as a result has a bias against NDs in this country in a very big way, because we haven't been one offered a seat at the table. So we haven't been offered the ability to quote unquote conform in
right.
terms of like what the DOs have been offered. We have the ability to be a part of the system. So we haven't one been offered that. So that's one reason.
Huge.
Uh, it's a huge one, yeah. And two, we still are considered, and this is part of where the bias starts to, really show too, is like we are still considered a lot of times, pseudoscientific. So
Facts.
we are not considered to be at that high standard of rigorous scientific thinking and scrutiny. Like the perception is that NDs don't care about science, that
Right.
we are okay with and more comfortable with traditional therapies. That's not entirely true, though.
It's not.
And we've talked about it before, how the majority of us have done our best to try to evolve with the quote unquote science and really make it a part of our practice. And some of us really go out of the way to say all the things that I do are evidence based. And it's like, okay. Um, but that doesn't mean go
Okay,
ahead.
I mean, I have issues with that term evidence-based, right?
Right.
Because I can't remember the exact figure, and I'm going to butcher this, so I should have looked this up. I didn't know we were going to get on this topic. But by the time we get the bench work, the research, right, and then it gets adopted into our medical practice, that evidence can be 20 to 30 years old, right?
Right.
So practicing like that dogma of being evidence-based is really not being innovative. It's not being on the forefront of what we're seeing clinically. You're going to forever be 20 years behind, right?
Right. That's right.
So evidence-based is has its merit, but it also has its limitations. And that's something that we don't give any credibility to, right? Are the limitations of evidence-based medicine.
That's it,
I'm not
because I
saying be
mean,
rogue. I'm not
no,
saying that.
but it depends on what one defines as evidence-based. And I've also thrown
Right,
around the term that likes to be thrown around, which is settled science, where they felt like, okay, the evidence came out and it's been given 20 or 30 years, and then it's been implemented in these institutions and in these systems. But
right,
before it's actually implemented or accepted within those institutions, within those systems, it's still somewhere in between evidence-based and pseudoscience, but it may actually be on the cutting edge. So I would actually argue that a lot of NDs operate more on the cutting edge because we're not bound by those systemic restrictions. What they consider, because this all gets back to standard of practice too, because the idea of standard of practice has to do with that idea of settled science, that this rigorous testing has been done, that the double-blind placebo-controlled trials have all been done, and all of this is settled because we've
right,
done what we need to do. This is all the hubris of the Flexner report once again, that we can achieve true absolute truth. We can achieve absolute truth. So until we get as close to possible to absolute truth, these
right.
things don't mean anything. But does that really, really actually happen in medicine? You have to also remember the other institutions that are pressuring the system. What about the drug and pharmaceutical institution? That's pressuring the system.
I mean, look at
So,
statins and cholesterol. What
yeah,
used to be an acceptable level of cholesterol was pretty high, approaching 300.
yeah,
Now now cholesterol, they want it at 200. I have reports of people that come to me and their doctors are pushing for a cholesterol below 150 and not with any cardiovascular history, right? It's
right.
different if you have cardiovascular history. That changes things, right? It changes
Yeah.
those reports. But without a history of cardiovascular event, then I see that pressure, right, to introduce the pharmaceutical sooner and sooner and sooner, and then it has a cascade of negative events potentially, right?
And I would
Some people might
argue,
benefit.
I would argue that is not settled science, first of all.
It's not settled science, and the thing about settled science is like just when you feel like you're on target. Right, that you feel like, okay, this is a really good, like, take the blood pressure recommendations, right? And they're pretty solid blood pressure recommendations and how you should approach that and the algorithms and what medications to start with and add and all that. But my issue is that people are changing. We're changing. We're evolving. We're becoming sensitive to medications that or medications are ineffective now that used to be effective, and we're seeing a shift. And we're going to continue to see that shift, which makes the science have to continue to follow that, right? So the whole idea of settled science is really a misnomer.
Yeah. And even if you really felt strongly that something was very well settled most of the time, that the probability of a treatment being effective for a certain circumstance was going to work, let's just even say 99% of the time, because I would argue that there's always a margin of error, that nothing is absolute really.
Nothing.
You also have the other side of what I had explained about this report in terms of its limitations was the dehumanization of medicine. So, we like to really call like the placebo effect something that's really terrible and awful because it's just like it's a as I say, it's like a handicap of research or whatever. It's something that affects the outcome of the science, and it affects the ability to really settle on the science. But in our model of medicine, we emphasize more of the patient care piece of our medicine. And so you can get better outcomes by being a better doctor for that individual actually, and that will actually elevate the efficacy of your treatment quite a bit. But that's thrown out in the standard research model because they don't that's why they have placebo groups, because they realize that placebo actually elevates the efficacy of medicine. So they want to remove all that out of the equation altogether and really just find something that will work 99% of the time. But I'll tell you, if you're a drug dictator, in other words, you spend 5 minutes with somebody and dictate drugs to them, it doesn't matter if that one trial showed a 90% efficacy, there's going to be probably less than 90% efficacy with that particular treatment in that particular person, most of the time. There are certain exceptions, but most of the time, I can say that safely in having seen it in clinical practice. But some may argue that, but it's true.
Right.
So, so that's kind of what we're left with, like I said, is this sort of, push and pull from the institutions, the powers that have been established within these systems, and we're sort of kind of left in the periphery here. Kind
So
of.
tell me, where do you think that naturopathic medicine is going to go in the future? Well, first of all, I should say, how has it adapted to that?
Yeah, good question. I mean, what's really interesting before I answer that is we've talked about this before, how uh, a lot of other practitioners have started taking some of the good things from naturopathic medicine. I'm not saying they're stealing them, but rather like functional medicine is something that was a big part of our medicine prior, is like learning kind of more of a holistic model of thinking and kind of more of a optimizing health and wellness sort of idea in healing. And also I think just a lot of functional practitioners tend to be spending a little more time with people, tend to be thinking
For sure.
more globally and systemically and stuff like that. So I think in some ways our philosophies have made their way into more conventionally minded systems and practices, and even some big hospital systems have a functional or an integrative wing now. So in some ways, the ideas have been slowly integrating. So I wanted to say that's a good thing, but the people, us in particular, have not really been fully integrating.
I was just going to say that people have not been integrated. If you look at, for example, I'm just going to bring this up, Scripps Medical, right? Scripps, I think it's Scripps Center for Integrative Medicine. Okay. And that's in San Diego. If you look at that, like when I was an ND, they talked a lot about how we had this collaboration with them. And when I was an ND, when I was a student, ND student, they talked about a lot about our collaboration with Scripps Center for Integrative Medicine. And if you look today, there's not a single ND on staff for them.
Mhm.
Like
Yeah.
not a single. I mean, they've adopted a lot of the principles, which I love. Like ultimately, that helps patients, right? So I
Yes.
can't begrudge that because that's patients are demanding integrative medicine and they're
Mhm.
getting it, and that is a win. The problem is we're still not part of it, right? We're
Right.
still left in the periphery. So
Yeah, they found what I realized over the last 10, 15 years that I would see is that there were NDs sort of integrating into systems in different places, but eventually
yeah,
those jobs no longer existed. I'm not saying they don't in some cases, but they were often replaced by a functional MD or DO, or
yeah.
somebody that was more what they considered more of a like-minded system provider.
And I
And
just last year, OHSU here in Oregon, they actually shut down a lot of their integrative medicine sector. And I don't know if it was, I don't know the reason. Surely not because of patient demand, because I would assume that patients were demanding that. But I think it was their acupuncture, massage therapy, like that sort of
yeah.
um, wing. And so I don't know all the details of that, but it's easily accessible. It was in the newspaper. There's articles on it, but it's likely
Yeah,
the lack of insurance reimbursement.
yeah, that's
It
part
wasn't
of the
possible.
problem too, is that in most states, as we know, and we've talked about, NDs don't have insurance coverage. And then even in the states that we have a good scope of practice and we could integrate into those systems, we don't have insurance parity.
Right. And
So,
what
I
does
mean,
that mean?
that's,
For
well, it's
those that don't
very,
understand, what is it? What I mean, what
yeah,
does insurance parity mean?
yeah. I mean, my understanding of insurance parity generally, to put it in the simplest of terms, is that we do not, as NDs, get reimbursed the same as MDs and DOs in
Correct.
many of the states in which we practice. And one of those states where there's a hot fight on that right now is the state of Oregon.
It's been a hot fight for a
It
minute.
has for a while. It's
Yeah,
big, a big part of our state organization, and several groups, grassroots groups, and different things, and a lot of the money and the funding and everything, any donation, all everything goes to trying to fight for insurance parity. Because in the state of Oregon, we have a great scope of practice, and we have been blessed with that for a long time. But one thing that we're really lagging behind is that. So if you're a provider that wants to be working as a primary care physician or working as a general practitioner, you can take insurance, but you don't get the same reimbursements as your neighbor across the way there. And
right.
yeah, that's not fair. That is an ND bias. That still comes from these really old ideas of what's a good doctor and what's not a good doctor. And we discussed before about our medical school training that it was much the same as other medical schools and stuff like that. And that really where we haven't had the ability to quote unquote get on the same level that they're looking for is the opportunity to apply for and actually be accepted to
Residency.
residencies.
Yeah.
The inability to become boarded, you know. Some of us would, and we would if we could actually, because there are quite a lot of people that really would love to say get a family medicine, uh, you know, board certification.
Right. I certainly would have. I would have done a residency and
Yeah, sure.
certified had I been
Yeah,
given the opportunity.
and we had the basic training and understanding to do that. And if we needed to have additional training in, say, emergency medicine, where I felt like maybe we could have been a little bit better there, there could have been ways for us to do that and fulfill that. Maybe we could have
Right.
created opportunities to have, mini residency or shadowing experiences or, some sort of internships or something like that could have been provided to us to get whatever they felt like we were missing. But
Right.
instead, to me, there was just sort of this automatic bias of no, you don't have a seat at the table. So as a result, we aren't seen as on the same level. So therefore, we shouldn't get the same reimbursements, even though we spend more time with patients and we debatably uh, treat more levels of their complex care in terms of their
Right.
multiple systems and different things and try to bring it all into balance. And so we have our place. And we also know when to refer to the specialists and do everything else.
Right.
We
Of
we would
course.
be really the majority of us who want to be in a system would be really good members of a system. And I really want to say that I've met a lot of really good NDs over the years in Oregon, in Washington, all over that would be good system people.
Good to
They
meet good
they
some
play
people.
nice, they're smart, they understand the limitations of when
Yeah.
emergency medicine is needed, uh, when you need to refer, all of that. It's all part
Right.
of our training, and it's the people who operate in it are really quite competent in it. That's the reality. That's the reality of
That's the
what I
reality.
see.
Can I share something that is like when I think back and look, I am appalled that this is a level of thinking that we tolerate. When I first got licensed, a lot of my colleagues moved to Central Oregon, right? And we had this little group, and one of our colleagues was thoughtful enough to create a Google spreadsheet that basically who are the friendly MDs, ND friendly MDs, right?
Right.
And so we literally had to make lists of when we referred somebody. And this is an issue, right? Like when we refer somebody, is that referral going to be well received? Is that person going to be nice to our patient because they were referred by an ND? There's so much bias against NDs that some patients are on the receiving end of the hostility, right? By some people in that system that aren't friendlies. And we used to call them friendlies. And how messed up is it that we tolerate the fact that we're just not accepted? And here we are making these underground lists of people that accept what we do and appreciate what we do and appreciate the care that we give, right?
Yeah.
It's that's messed up. And it took me like until this year to go, that's really messed up. It's time that we
Yeah.
change that. We need to be valuable members at the table as well. And
Yeah, I mean, I don't know what more we need to do to prove ourselves in some ways. I think those that like I actually do practice with several MDs, and I have in several points in my career, and I
right,
know that when we're all in the same room, we understand the value of each other, and
absolutely.
that a lot of times we can be better together than we are separating ourselves. And so I've seen that firsthand over the last, 12 years of my practice over and over and over again. And
Yeah,
so once again, there's the reality and then there's the perception, right?
right.
And yeah, so what have we done as NDs? We've all had to try to adapt, as humans do, right? So we adapt, we create adaptations, and those are ways in which we try to, just prolong our own existence basically within the
It's
system. And so,
it's forced us into like cash pay models, right?
right,
Because we don't get the insurance reimbursement. And
that's right.
like you and I spend 60 to 90 minutes with somebody, sometimes upwards of 2 hours, and your insurance reimbursement is $125, right?
Yeah.
That doesn't pay for your time.
No, It
we go
doesn't.
broke quick, right? Like our overhead is much bigger than that. And so
Yeah.
that's an issue, is it forces us into a cash pay model sometimes. And we've seen a big resurgence of concierge medicine, not
Right.
just NDs, but MDs, right? I mean, they're
Right.
starting to see that the insurance model doesn't necessarily fit them either.
Even if we reached parity, we would still have a lot of the same problems. Is that the insurances are not, the reimbursement rates are not in line with cost of living now for the average person in this country, or it doesn't, in state by state, has it adjusted to inflation? Not entirely. If you're not seeing 15, 20 patients a day, are your reimbursements really paying for your house and your car anymore?
No,
Or
they're not.
whatever
Yeah,
the system is requiring of you.
right.
So if you start saying, no, I'm not going to see 20 patients a day, I'm going to see 5 to 10, but I'm going to spend more time with those patients, you're not going to get the insurance reimbursements that are going to pay you nearly the same way. So, one, you're probably not going to be in a system because they won't allow you to do that. Two,
Right.
trying to be independent is going to have more overhead and more of these issues. So, what do? You either become a hybrid where you go concierge and you still take insurance to some degree. I practiced in one of those places before,
Right.
uh, or you just go straight cash, and maybe you do cash and concierge if you really want to get fancy. And what does that do? Well, unfortunately, it does reduce access to the medicine that you provide. But the medicine that you provide to those people is top quality. It's better in every way, and you don't burn out as quickly. So these are all just adaptations, and I want everybody to know, like, don't blame the person. It's like the system is really the problem here. When
Yes.
you see these things happening, it's like we're all just trying to do our best. Whether you're the guy working or girl working in the system, trying to get by, trying to live your life, trying to support your family, or the person that had to close their practice, adapt, move, and change to, or stay, for example, like in the West Coast where we tend to have more favorable practices. Like I'm from Pennsylvania. Would I ever be able to move back there? Not easily. Not if I wanted to work.
Right.
So,
Right.
not if I wanted to be successful.
But
It would be
then
a lot more challenging.
I feel we're going to see a big shift in that as well. And I can't recall if I touched on this in a previous podcast. I know we're kind of overlapping with some of our previous podcasts,
Yeah.
but Oregon was on track. Like they have a committee right now to essentially be the first state with a single payer health system, right? Universal health care. And
Hmm.
so Oregon is moving towards that model, or at least they're trying to figure out a way. And I just read something, just last night about, Tina Kotek, our governor, has some serious issues with moving forward that universal health care. Like there's some questions, some significant questions. And while she's in favor of it, she's also like, this isn't fully ironed out yet. You need to go back to the board and, iron out some more of these details, which I appreciate. I think Colorado, California, and Oregon are all kind of similar in their efforts to try to have universal health care. Here's a caution in that, though, and this is where I really take issue with the universal health care. It sounds great. It really sounds great. And as much as I want access for everybody and equal footing for everybody, what it's going to do is all these concierge doctors, all these cash pay doctors, we're going to be snuffed out. And that's my caution. In the state of California, it's illegal, and I believe it was like this in Oregon. I remember a doctor that I worked for, he mentioned that it was illegal for, if you're on Medicaid of that in that state, to seek out cash pay doctors. And
Wow.
so effectively, if you can't get your needs met within your Medicaid system, your assigned doctor, you don't get your needs met. It
Well,
doesn't
how has
matter.
that worked in Canada? How's that gone in Canada?
Well, and maybe they don't have the same, right? Not all states have that same law regarding
Right.
Medicare and the ability to seek help outside of or excuse me, not Medicare, Medicaid, and the ability to seek help for your condition outside of the Medicaid system. And so that's a problem. Like, and I can see it moving towards that to where, I mean, just in the time that I've been in Oregon, I used to be able to order labs for Medicaid patients. I used to be able to order imaging. I used to be able to see them. And now I can't order labs for them. If you're not contract, you just can't service
Right.
a Medicaid.
Right. Right.
And and we're slowly moving towards that. So as much as we're trying to adapt this model, and even MDs are trying to come out and adapt, to make it, fit their lifestyle and to fit their essentially their moral compass, right? and we're getting more and more limited, more and more pigeonholed with the insurance companies. I was just visiting with an MD a couple of weeks ago, and he was sharing that every year his rent goes up, right? 3%
Mm.
every year. His rent goes up for his office space. He has to pay his employees more. Like all of his costs grow every year, yet his insurance reimbursement shrinks every year. And he was
Right.
like, "What model have we adopted that I'm essentially, at the mercy of the insurance companies for reimbursement?" And he said, "Yet I can't raise anything because to meet the costs, right?" So every year his income is shrinking.
Yeah, I mean that's it. It's just it's not there's not adaptation by the insurance companies and the institutions here to allow for cost of living and just operations and
Yeah.
normal business stuff. It's just it's crazy to think that the system is so tone deaf about that in so many ways because it seems like it is. So if you put a universal system into place, who's the authority over what the reimbursements are and who can get them and what the rights of the individual are to get the health care that they need for the condition that they have. There should be a fundamental freedom to see who you need to see. There should be access, and they're always talking about access. This is going to provide more access for people, but if it's not getting the people to the providers that they need, then it's actually hurting access. And why, and we just mentioned how it could affect the ability to get to the providers that those people need. It may be the reimbursements rates, it may be, contracts that get developed or not, in violation of those contracts. And so if they're expecting some universal system, then every healthcare provider is expected to apply or contract with that system. That's already a broken system. I don't think it's going to work
Right.
unless there's some incentives there for the individual that's part of that system, the healthcare
Right. And we know
practitioners.
that and NDs and MDs already limit the number of Medicaid, Medicare, patients that
Yeah,
they have, right? Because essentially you almost lose money with those patients. And it's so sad to say,
you
but
do.
you do, like with your cost of overhead and your insurance reimbursement, you lose money. So you have to put a cap on those patients. And then unfortunately you start having like what insurance do you have? Oh, Blue Cross Blue Shield, great. They're a good payer. We'll take you. So
Right.
my caution with all the universal health care is that we're going to see it, it might not go smoothly. I'll just say
We at
that.
least need to
Might
have more
not.
conversations. The first conversation we need to have is bringing it back to the beginning here. Maybe we do need a new Flexner report. Maybe we do need a new
Right.
standard of a new standard in what is good science and what is good patient care. That's number one.
Right.
If we can go back that far and just all be aligned there, I think that can go a long way. Because
Yeah.
if we create a universal system within the system that's existing right now, to me, it's set up to fail, to begin with. We have to go back further and actually have these difficult conversations on what is actually limiting us in our healthcare in this country. And it's all those things that we mentioned. It is the plight of the individual here within that system and the plight of the patient. And we've talked about the plight of the patient many times because there's unfortunately they're just wrapped up into, and I'm somebody's patient too, are you, I'm sure. We are all
Right.
somebody's patient because we all need healthcare at one time or another. So it's a balance between like what the needs of the person are and the needs of the practitioner. The fact is we have less we still have a very high demand of doctors. We still have less access to care than we need.
Right.
There needs to be more people out there doing this work. So you have to have some kind of incentive. A lot of people left the medical field during the COVID era for several reasons, but it was overstressed, overextended, overtaxed, and overexposed. The limitations of the system were exposed right there, clear as day, for
Right.
everybody to see. And what have we done? How have we responded to that? Have we responded with a change in our system? Have we created a new Flexner report? Has anybody been where are the philanthropists that are going to charge the next, Flexner to get five white men together to talk about this?
Yeah. Yeah. Maybe it should be the Kunkle report.
Yeah. Yeah. Well, I mean, I think you should have everybody at the table at that point, right? Because
I
like
agree. I agree.
everybody should be there because from different degrees to, obviously male, female, different ethnicities. You need everybody at the table to create an effective report. This report was done in a very like this is archaic. This is old. This was notably racist as mentioned. Like we
Right.
can't continue to operate out of that. We have to understand the most important way to know how to create meaningful, effective change in the future is to understand the history. And that's my whole point, is to understand where we've come from, where we've been, where all these ideas have come from. And the more we can understand that, the less likely we're going to repeat the mistakes of the past.
Right.
The more that you ignore history and what happened, the more you're just going to be like, oh, this is a good idea, and then it's not going to manifest that way. It's going to cause problems. It's going to set us back. We don't have time to be set back.
No, we
Uh,
don't.
we're in the midst of a health crisis. We've said this before. There is way more complicated chronic illness in general in this country than there ever has been before. And you could say, oh, well, we're just diagnosing it better. It's more than that, believe me.
It's way more than that.
Everybody in the trenches knows that it's more than that. I'm telling you, we all do. Some of us have probably left medicine because of that, because we've thrown our hands up in frustration that we can't help these people like we used to be able to.
Right.
Um, and a lot of people have just one of the main reasons, and we'll talk about this sometime about physician burnout. In my opinion, one of the main reasons is the pushback, like the frustration that we're one not given the tools we need to operate within the system, or we're not, being appropriately compensated to operate within the system. And, we're not seeing maybe the same level of successes that we've once, seen in medicine too. I don't know. I could be wrong, but I feel like
That's certainly what I'm seeing.
it'd be more satisfying to be an effective, helpful doctor who also, gets paid a decent salary and can pay off their debts and support their family and everything.
Yeah.
So
The
the
small
time is
things, right?
now.
Small
Yeah,
things.
small
And
things.
you
We
know,
all want the
it
same thing.
on that the interesting thing you mentioned, given the tools that we need to treat these patients, like if you look at California, the California Board of Pharmacy has effectively like what have they taken away glutathione yet? Or is it on the chopping
Oh,
block?
they're trying. I mean, it's been on the chopping block so many times, and there's been a big push, obviously, with glutathione. If anybody is aware, that it helps first responders. Folks that have had exposure to
Exposures.
wildfires and
Yeah,
a lot of toxins and oxidative stress in their system. And glutathione is your primary antioxidant. It's just that glutathione cannot become a registered pharmaceutical drug with a patent. It just can't.
right.
It's not. It's a nutrient. It's a natural forming thing in the system, and you can't patent nature.
But the
So,
FDA, sorry, go ahead.
oh no, no, go
Get
ahead.
excited and interrupt. Oh, it just the FDA is constantly taking medications away. Like
Yeah.
NAC was on the chopping block there for a while. I can't even imagine NAC is on the chopping block. Is one of the most benign, beneficial. Please don't just go out and take it if you're out there.
Yeah.
Just,
Yeah.
take it under the supervision
Don't
of a
worry,
doctor.
that's on my disclaimer.
Okay, okay, good. It's in the disclaimer. Good. But like there are a lot of medications out there. Tirzepatide, as of, March 19th, tirzepatide that's that GLP-1 agonist for those of you who don't know what tirzepatide is. Tirzepatide is the brand name, excuse me, the generic name for, is it Mounjaro? I believe it's Mounjaro.
Zepbound too, I think.
Is that,
Yeah.
yeah. And so, we're not going to be able to have that compounded anymore. Well, compounding was this much more affordable for patients than the brand name, right? So now patients will have less access because it's no longer under shortage anyway, so that we can't get it compounded anymore. There's a lot of medications like this that they are just slowly artemisinin. It, I
Hmm.
I'll save my breath on artemisinin or artesunate right now. Artesunate was
Right.
one that we lost that battle and is now a pharmaceutical.
Yes.
I mean,
Yes.
in case anybody watched that, within a matter of 2 months, the FDA said there was no medicinal value for artesunate. 2 months later, singing the praises of this new pharmaceutical that just
That's
got
right. And the guy that
529.
found it won a Nobel Prize.
Yeah.
So it doesn't
So,
matter. So that whole
but now it's
scientific
not
standard.
accessible. And it's not accessible. We used to use that a lot in practice, and
Right.
we can't get it now. It's unaffordable because it's under patent,
Yeah.
right?
I mean, the truth is, and this isn't conspiracy, there is a gradual erosion of non-conforming therapies, like natural therapies that can't be patented, cutting edge therapies that like repurposed medications or repurposed substances that have been found through vigorous scientific study to
Right.
affect a certain function in the system, but are not on the list of one or two FDA approval lists. Uh, but they're still safe, and they've done vigorous safety studies on other conditions, but they're not allowed to be used for these particular conditions, for example.
Right.
And obviously, nature gets attacked the most because the supplement industry is not regulated, and that drives these people crazy. And it is a big money industry too. And as a result, it can be taken advantage of. You can get really poor quality supplements. We'll do a podcast on that
And
sometime.
yeah, that's a good
Talk
point.
about quality control and stuff like that. So it's like anything, it's not black and white. Like there's always a need for change. There's always a theoretical
Right.
concern that can be a concern. Like compounding pharmacies need to undergo rigorous, testing and quality control because they're
Absolutely.
creating medicines for people, and those medicines are being placed in their body. And if they're being placed in their body through intravenous means, for example, you better bet that the risks and the stakes are higher than whether they're taking it through their mouth because you can eat dirt and not die. But putting microbes that are in dirt in your blood probably isn't the best idea. That's just an example. So,
Right.
but anyway, I digress. My whole point is that yeah, there's been an attack and erosion on medicine that's not like the standard of medicine, and this all goes back to that same bias that the only medicine that's good medicine is the medicine that comes out of this particular, line of scientific thought and standard, and that medicine has to be settled by some authority, which is mostly just humans, by the way. It's not like there's a scientific authority that's like saying yes, that's good science or no, that's bad science. It's like there's a group, like a board possibly or something that's saying, the FDA, for example, like gets a few dudes together, or, sometimes ladies too, and says we think that there's evidence lacking for this. Our opinion is that there's evidence lacking for this, and
Right.
those same things happen in other parts of life, like the IDSA, the Infectious Disease Society of America, and sort of what their perspective may be on, Lyme disease and Lyme disease management. I mean, we can go on and on. We'll talk about all that stuff sometimes too.
Yes.
So you can say that we have this very vigorous, very high standard of scientific rigor, whatever, to be the best we can be and to be the safest that we can be. But there's a whole lot of human opinion and a whole lot of human bias that's wrapped up into it. And there's
Right.
a lot of pressure from the pharmaceutical and the financial
I was going to
system,
say a lot of conflict of interest is what is wrapped up in.
conflicts of interest, really, that make it much more challenging to operate around. So if
Right.
you're just an individual trying to do, I'm just a little country doc trying to do what's best for my patient, I'm going to be encountering pressure from all of those different things. And
And
that pressure is going to
bioidentical
trickle.
hormones
Yeah,
are on the
perfect
chopping block,
example. Yeah,
right? They're trying
yeah,
to take those away. I'm like, I
right.
can't even imagine taking away
What's the
bioidentical
problem?
hormones.
Yeah,
Right.
yeah,
Yeah.
bioidentical. Oh no, like let's do synthetic instead. Okay, well, there's been a lot of
Right.
studies on the risks of synthetic hormones, on cancer risk. There was a study in 2016 suggesting oral uh, synthetic estrogens could contribute to the development of inflammatory bowel disease. Oh, that doesn't sound good. So there was a lot of concerning things there. Yet, we're gonna choose. So that's the thing about data. Remember this. You can choose and use science to support any line, not any line, but you can support two different
Almost.
viewpoints.
Yeah.
You, you know, you,
For every research article that's out there, you can find an equal and opposite research article
yeah,
to
you
prove the
can
other
find
side.
evidence that's suggesting otherwise. So
Right.
anytime you're making a decision, it is sort of like a probability uh, decision that you're making. You're saying, okay, well, there's a lot of good research suggesting this is good. And then I'm looking at that individual in front of me and I'm feeling like there's probably a lot of good clinical evidence that this is going to be good for this person. But I'm still going to tell them the risks and benefits of this particular treatment and all that kind of thing. And so even the basic fundamental freedom to do that, which is the art of practicing. Practicing is what it says it is. It's an art
Right.
form. It's practice. It takes a lot of creativity and it takes a lot of experience. It takes a lot of wisdom. It takes a lot of learning that person in front of you to do it properly. Can
Exactly.
you imagine that person just simply trying to operate in that mode, being so overwhelmingly pressured, and that pressure then trickles to their boards and to their their licensing boards, for example, and
Yeah.
other regulatory systems that they happen to be a part of, and that contributes to the erosion of our practice. So as long as this, Flexner line of thinking is the standard line of thinking, and the systems that are operating continue to have the power that they have to operate, these things are going to continue to trickle down to the individual, and that's the individual practitioner and the individual patient. And that's really the take home from all of this. So this isn't like a unique ND issue, but it is certainly a issue that any practitioner, I'll go as far as to say that any practitioner that puts the patient first in terms of their care and their needs, so it considers all the different, science that's out there, all the different traditions, all the different experiences that person has,
Right.
and tries to figure out what is best for that individual. Any one of those practitioners is going to get pressure and pushback from the established systems. Any one of them.
Yeah.
That's
Sure.
the hard truth of it, honestly. So
Right.
I
Ooh,
mean,
that's a
yeah,
good, that sounds like a good wrap up, Jamie.
that is a good wrap up.
That was a
Yeah.
good, that was well stated.
Yeah. So I mean, I hope if anybody's interested, like I said, I'll maybe include that paper on the Flexner report, or you can look it up. Don't always trust Wikipedia. Wikipedia does not like naturopathic medicine, by the way.
Right.
Do not wiki naturopathic doctors. It's kind of hard to read.
Yeah, it is.
Uh,
That's brutal. Talk about a bias against NDs.
I
Woo.
I know. It's crazy that a public encyclopedia, quote unquote, is sort of the same idea. It's just like it's a system response. If you go in and try to change anything, there's somebody who's immediately changing it right back.
Yeah.
And so there's like an authority that keeps that information at a standard. And so what is this standard? You it's just crazy. So
Yeah.
anyway, thank you for listening today. Thank you for listening to me rant about bias in medicine and bias in institutions and bias in, everyday life, honestly. And I think we can be better. So just remember the general ideas that, know your history, first of all. Don't neglect history. If any younger kids are out there still learning history in
Let's not
schools,
repeat it.
don't repeat history. It's
Yeah.
best not to. Keep reading. Read from reputable sources. Don't just read Wikipedia. Don't just read people who have the same opinions as you either. Be willing to expand
Get out of
your
your echo
thoughts.
chamber.
Exactly. Get out of your echo chamber. Get out of your bubbles. Get out of
Don't put it
your
on Chat GPT and ask Chat
No.
GPT to give it to you.
Don't trust AI.
Don't trust
Not
AI.
yet. I don't think we're there.
Yeah.
Use it as a tool, but don't rely on it for everything, trust your own critical thinking. Cultivate critical thinking. Have
Mm,
conversations with people. Have conversations with people that don't have the same viewpoint as you. Talk to your neighbor. Do it respectfully. Talk to somebody across the aisle, wherever they are. If they're politically across the aisle, or if they're across the aisle in medicine, talk to a hospitalist if you're an ND, whatever.
mhm.
Just get out there and talk to people, because as soon as you do that, as soon as you lay down some of those biases, acknowledge they exist, that's fine. We all have them. It's totally human to have bias. Don't worry about it, okay? Don't beat yourself up. Just let it go. But just get out there with an open mind and talk to people. That's what I ask, because you'll learn a lot.
Yeah,
I promise you.
yeah. I've learned a lot.
Yeah.
Yeah.
What are your final thoughts there as I continue to rant?
I would say what struck me as you were saying, like, get out there, talk to your neighbors, talk to people across the aisle, right? I have to 100% agree with that. Not just because you said it, but you're pretty
Thank
smart.
you.
So, um, it, but mainly because, like, we all want the same things ultimately, right? We all want the same. I shouldn't say we all want the same outcome, but essentially we all want peace. We all want to get along. We all want our piece of the pie. We all want, right? And so what I think where we differ is the vehicle to get there. And so if you can appreciate the fact that most of us, the vast majority of us all want the same things, and we may disagree on universal health care versus keeping it commercial versus, that's those are secondary issues. But
Mhm.
back to your point about like being human first, like be human first, right? That's a primary issue. Our
Yeah,
humanity is a primary issue. Secondary is everything else. Tertiary,
exactly.
all that. So, yeah, good talk,
Yeah, I
Jamie.
used to say, I think one thing sort of, I think somebody used to tell me, maybe this is just an old way of thinking too, that like, heart before head, like
Yes,
follow your heart and like connect with the heart because that's something that we're sort of missing. And it's where, we kind of take that whole monkey brain thing out of the equation. We're not overthinking everything all the time. And we kind of get down to the fundamental, uh, human connection, empathy, things like this. And
right.
I don't fully always, it's something I've explored for a long time, and maybe we'll talk about it again. But try to connect more with the heart and a little bit less with the head, because you're not, if you keep trying to find all the really, really big answers, you're not necessarily going to find them right away. So you have to kind of take a step back sometimes, and there are other ways that you can operate. And I know it's a little abstract, but I'll explain it more later because I'm still trying to understand it. But there's other ways that we can operate in this world. There's other ways that we can carry ourselves and interact with the world. We don't always need to have every single answer, explanation, rationalization, everything. The world is a crazy place. You got to laugh at it sometimes. It's
Yeah,
it's it's the divine comedy, you know?
pretty crazy.
It's a crazy world. It's a crazy life. It's a crazy existence, So just, let it go sometimes, laugh about it, and let's all get together and find solutions. And we need to go a little deeper than
Yeah,
where we have.
I agree. Here's for reform. Go 2025. Let's make this a year.
Yes,
We reform some things.
let's do it. Let's do
Let's do
it.
it.
All
All
right.
right.
Well,
Flexner
thank
2.0.
you. Thank you for listening. We'll be back again in a week or two. Janelle and I will probably be doing a little bit of solo work here and there as well. Maybe releasing some smaller videos. You don't have to listen to these really long ones all the time. We'll see what happens. But I'm excited with where we're going. And everybody have a healthy, happy day. And Janelle, good to see you. Thank you so
Nice to
much.
see you. All right. Take care, Jamie.
Thank you. Bye bye.
Till next time.
Thank you for listening to our podcast, Confronting the Complex with Dr. Janell Payne and Dr. Jamie Kunkle. As a reminder, the views, thoughts, and opinions expressed by Dr. Jamie Kunkle are solely his own and do not reflect the views, policies, or positions of Gordon Medical Associates or its affiliates. Any content, discussions, or advice shared on this podcast are independent of Gordon Medical Associates and should not be interpreted as a representation of Gordon Medical Associates. Gordon Medical Associates does not endorse or take responsibility for any statements or viewpoints expressed in this podcast. Thank you, and I'll see you next time.